James Harden is not available to you, the only hope you have is that.
Hi, everyone. Welcome to today's meeting. We'll get started in just a moment as folks enter. If folks can make sure they stay muted while they're not talking, that'd be great. Happy Thursday to everyone. Excellent. I think we're just waiting to admit a few folks. Welcome to today's Connecting for Better Health meeting. This is our second one for the month of October. I know many of you were at the Health Plans Conference this week, so thanks for stopping by the event. We co-hosted with some other folks there. I'm Robbie Franceschini with Blue Path Health. We help to facilitate the coalition. Just moving to our next slide, just for folks who may be new today to the coalition and the work we do. We will begin here with just intros real quick. We'll then dive into a recent white paper that several of us, including our partners at Stewards of Change, just published with the California Healthcare Foundation around consent, really in the context of consent to share information. After that, we'll touch on a few data exchange framework updates, some exciting news related to QHIOs, as well as a couple other informational items for you all. We'll also share out some recent findings from the California Health Interview Survey. We were joined recently by some of the leaders of that group out of UCLA. And then we also will end with several news and announcements for everyone too. So just to provide a little bit of context to the coalition, we meet twice a month. Our vision is that every Californian and their care teams have the information and insights they need to make care seamless, high quality, and affordable. And the priorities for this year that we've been super focused on are around DSA education and execution, getting folks to sign and start sharing by January next year. Also around funding for this work, integration of social services data, and DSA and PMP development related to the framework too. If folks would like, feel free to use the chat to introduce yourself, share links, questions, thoughts, information you'd like to share with others as well. We welcome you to do so. So first to kick off, just want to say thank you to partners at ManifestMedX and Unite Us for co-hosting an after hours event at the California Association of Health Plans Conference. And big thanks to all of you that attended that as well. I think I wasn't there personally, but it sounds like we had really good turnout. I was there last year and it was certainly fun catching up with coalition folks who were there as well as reps from health plans. But we really wanted to just say thank you to all of you who came out and made that event a success. So moving to our kind of kickoff presentation for today, we wanted to share out about our white paper related to consent to share. I know we've got Daniel Stein from Stewards of Change on the line too, Daniel, I welcome you to jump in case we miss anything and share your reflections as well. But we'll drop the link in the chat for folks to be able to access this white paper. I know several of you have from the newsletter. But really moving to the next slide, what this work aimed to do were a couple things. We started this almost a year ago with the foundation and the team there, setting out a couple key areas for exploration. One, around the need for consent to share practices in California. Number two, around the steps needed to implement consent to share and make it a reality in California where it may not be today, from policy as well as operational perspectives. Relatedly, describe scalable projects and practices that are testing and refining the use of universal consent forms and shared consent management systems among stakeholders or organizations. And then lastly, provide recommendations on how to improve and advance consent to share in California. As part of this project, we did a couple things. One, we reviewed relevant laws, provided some policy context too, as you'll see in a moment. We also conducted interviews with a number of stakeholders from health systems, those working on closed loop referrals, as well as CBOs, consumer advocates, as well as several attorneys as well, really to solicit input on how to shape the recommendations for this paper. We had lots of really great feedback, sometimes conflicting in terms of what different folks shared. But I think what we really sought to do with this paper is create kind of the foundations for a launching point for more work on this subject, whether that's at the policy level, whether that's trying to figure out what's next in terms of scaling some of the work that's already been piloted or tested out in the community, and what can we continue to learn from other communities around the country as well. So to provide a bit of context for the white paper and the genesis of this work, I think two key things arose as kind of creating the need for this. One is around the data exchange framework, where CDII is really looking to advance the sharing of both health and social services information. That I think is, as many of us know, and as many I think we'll see in the white paper too, is tricky because health and social services organizations have myriad laws that affect privacy and confidentiality or lack thereof. And it's often difficult for organizations to make sense of all those laws and implement them into workflows to make sure that consent's being gathered at the right time. I think additionally, as we saw in a lot of the interviews too, there's also different cultures that exist out there in different sectors related to when consent is needed as well, whether that's because of professional standards of practice, ethics, or the sense that this is how we sort of do things in our community. Additionally, as many of you are knee deep in CalAIM work, which really focuses on whole person care, addressing social determinants, integrating behavioral health more neatly with managed care in California. Again, I think this is where we're kind of operationalizing that integration of different sectors, and where data sharing, as we all know, is a key piece of that work, and where, again, consent comes up in practice. And then other initiatives, that we think also, implicate this work too, the community schools work that the Department of Education has funded, where, we're looking to create these holistic, whole student, whole community-centered schools in California, where health and wellness are key pieces of that work. As well as other projects like the Child and Youth Behavioral Health Initiative, where issues like minor consent come up and are implicated too. In terms of moving to the next slide, what are some of the requirements we highlighted when it comes to consent to share? One is the need for clarity on the legal landscape. What we heard from many interviewees is that there are often both real and perceived legal obstacles to sharing information. So, I think we especially heard this a lot from attorneys that, there really are real obstacles, right? It's often tricky, especially working with different clients, to craft data use agreements, help develop, comprehensive consent forms. But there's also, a perception too that this is just too hard. And that sometimes, clients or communities just don't want to share information because gaining the relevant consent is just too hard. We also heard too that, people really enjoy and appreciate the guidance that the state has put out. So both the State Health Information Guidance, or the SHIG, that's maintained by the Center for Data Insights and Innovation, or CDII, as well as the CalAIM Data Sharing Authorization Guidance that DHCS maintains, that these are really helpful in terms of understanding, how to interpret the law. Some of the obstacles there, I think, are, not all my use cases are captured within the different ones that are illustrated in those guidance documents, the need to continuously update them to make sure they're reflecting the law, as well as making sure that they also cite and reflect each other so that there's really kind of harmonized guidance. Additionally, a digital identity strategy came up too, really around recognizing the importance of trying to marry this work with the work underway through the digital identity strategy to tackle that issue specifically, that it makes sense to in terms of efficiency to also attach consent to that work as we're moving forward with policies and procedures on identity, as well as potentially procurement, other initiatives as well, to make sure that we don't lose sight of consent. And then lastly, around health data standards, this came up especially in a lot of the more technical discussions. How do we advance a lot of the work that's going on around greater granularity, whether it's for consent or more generally for patient preferences, where they may want certain data shared or not, that often it's just hard for vendors and organizations to be able to segment that data as well. So one other item we outline in the paper on the next slide is some of the key considerations we heard around scaling consent to share. Trying to figure out, what would a uniform approach in California be able to look like across the system? And a couple key things came up here. One, around the use of a universal consent form. This could be kind of take a couple different avenues in terms of what it looks like. Some folks brought up, a statewide form or programmatic form similar to the one used in AskMe. A partial form that, hey, this is language blessed by a state agency, that if you use this, you're legally compliant. To other, I think, interesting ideas too, can we think about how we might enshrine a consent form into law similar to what they do with probate in California? I thought that was kind of an interesting suggestion. So how can we kind of advance more universally shared consent language? The other is around implementations of governance to include individuals with lived experience, that as we advance policy and technology work at the state level, that we need to make sure that we're continuously including, patients or consumers in that work, those who are providing their consent to share information, that's critical to getting this right. The other, additionally, around type of information shared and permitted uses of shared information from, legal and ethical perspectives. What is it that, making sure that folks are adequately appraised of what's going to be shared when they do consent to sharing information, and making clear to them also what those uses are. Weighing too the benefits and risks. Similarly, kind of on the flip side, how do we adequately balance the need to gain consent as well as the need to share information when it needs to get shared with providers? I think that's really reflected in a lot of our laws today, right? Some laws are pretty permissible. You don't need authorizations to share information. Some are a lot more stringent, where you need to specify the types of data, who it'll be shared with, and how do we adequately analyze those laws, as well as kind of policy on the ground as it comes to how those laws are put into practice. And then lastly, just around revocable consent, this came up a few times too. How do we ensure that folks can revoke consent? How is that done from a policy and a operational perspective as well? And then additionally, to kind of illustrate these key considerations, we highlighted a few programs within the paper. We did have a section around the Medi-Cal AskMe pilots. We also touched on those in our first webinar in the webinar series related to the paper, where we invited all of the HIEs and CIEs, as well as their partners who participate in those pilots, to share out their findings. And then we also highlighted a couple California-based programs outside of AskMe to show how they are approaching consent. So we included San Diego 211, as well as Alameda Care Connect, and Sonoma Connect as well, which at the time was kind of in the midst of developing a lot of these materials and in their shared CIE as well. We also touched on other states. So that includes the Washington Healthcare Authority. This is that state's Medicaid program, which procured a consent management solution to first start with behavioral health data and consent in that context, and ideally work from that beyond that use case to others, as well as Arlington County, Virginia, and the Michigan Health Information Network. So a couple different sorts of entities with different models, geographies, constituencies to show how they're approaching this work. And a couple aspects highlighted, what kind of data is shared based on the consent that is given, how do they obtain it, where are these consent forms accessed, how do individuals have access to them, again, getting to the issue of revocation, what's the governance, especially around how are, patients or individuals or communities involved in this work, how's it funded, and what are the next steps in terms of how they want to kind of scale or expand this work. I do see a question in the chat. What about looking to POLST? Has that been looked at as an example for conditional consent? Good question, Michelle. So a couple points on that. I know there have been pilots in the past around ePOLST in several communities in California that CHCF has funded. There are also in AB 133 several years ago too, was an inclusion of the creation of an ePOLST registry within the EMS agency. And I think right now that work is they're still putting together the structure for how that will look. I think one issue there is around funding, but I think that's a good example to bring up, perhaps in terms of both, challenges and opportunities in terms of creating kind of a registry or shared solutions when it comes to consent, is looking to POLST examples. Just to kind of wrap things in terms of where the paper leaves things with the recommendations. There are a couple in here. One is to devise and launch a communication and education effort to accelerate the adoption of legal interpretations and ensure, alignment with sub-regulatory guidance. We had a really good discussion at the webinar last week around legal considerations on this topic. And I think that one of the things that came up is, the state certainly has a role in this, but so do all of us, whenever we're in different venues or webinars on our websites, to make sure we're highlighting the state health information guidance, as well as CalAIM guidance as well, making sure we get the word out there. It was great to have a former regulator on that webinar to discuss, there's, you can only put things on websites so much, on state websites or federal websites. And, it really takes those of us out in the field to get that information out there. Number two, around advancing efforts to develop consent to share technology, standards, and policy. I think really calling again on, those in leadership at the state, as well as those plugged into this work here today, to really help, drive forward those standards around, being able to segment data. Thinking too about where do we start in terms of that shared technology? What level is that at? Is it at a county level, a QHIO level, a state level? We heard a lot of different ideas in the interviews. So, I think that's definitely an area that needs further discussion, is like, where does this work really sit? I think with the Ask Me pilots, certainly that tested it out at the HIE and CIE level, which seems like a promising place. Additionally, as we mentioned around standard consent forms, really using those findings from the Ask Me pilot to inform further work related to Medi-Cal. Another issue that came up too is we need similar forms in the commercial context. Individuals who are on commercial health plans and their providers are not subject to the same waivers of state law that those in Medi-Cal are. So we have different legal regimes out there. How do we kind of make sense of that in creating shared forms? And then additionally, thinking about statewide consent management programs in parallel with the digital identity strategy. I think key there is, like, again, how do we advance that work on a policy level with identity work as that moves forward? And then relatedly to funding, as we fund, procurement of identity management tools and such, making sure we don't lose sight of also making sure to continuously fund consent management work as well. I'll pause there. I'd love, Daniel, if there's anything you'd like to add that, stuck out to you as we were doing this work in terms of, key findings or learnings that we should share.
Thanks, Robbie. Can you hear me okay?
Yeah.
Yeah. So I think you covered it really well. The paper is a pretty concise, provides a lot of concise details on a lot of the topics you raised. So I really recommend people read it. It's a really a quite good read. A couple of quick things. One is, the thing to remember, and I think you touched on it, is California has been on this journey for 15 years now. So it just hasn't popped out of nowhere. But the really strategic and ongoing persistent work, unlike most other states that I've experienced working with, really sets it up to be able to do something at scale, which is really exciting to see that many of the foundational components are in place, and there's been a lot of work going on already. So I just want to cheer the leadership, and I want to, everybody who's been lending their shoulder to the flywheel. It hasn't gotten there by chance. There's been a ton of work that's gone into it. And so it really feels like it's at a precipice of being able to do something at scale. I mean, there certainly have been efforts in counties, and maybe Washington is the first state, and Maryland maybe is doing some stuff in that regard. But in effect, doing something at scale that could potentially affect all counties is really a big deal. And I think it's garnering the attention not only in California but around the country. And it's ambitious, and it is profoundly complicated, as one might say. And the question is, how do we do this in a way that doesn't require 58 counties to invent it 58 times? That was one of the questions I brought up on the legal conversation last week, which we didn't have a chance to get into. But obviously, California has a tendency of replicating many, many, many times. So I'm delighted to see, the state representatives involved, and a larger concept really of a utility or a service, so that it doesn't need to be built. And this we've heard all across the country, as well as in California, that it could be something that counties tap into as a service, as I said, as opposed to building it many, 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 many times and having to coordinate that. The other point that I would raise, which I think is confounding to many organizations, and I think we heard this a lot, is because consent in many ways is what we refer to as the interstitial tissue. It's between programs. Consent within a program is easy to acquire and to manage, but exchanging those consents so that data can actually flow, not only being the first step, but it's also in that space where nobody really owns that, right? Except maybe two providers who are trying to exchange on behalf of a client. So there's a governance and a strategic question around where does consent live, and who has the authority to actually sit over it and has the responsibility to address that. And I think that's a question that I don't think it's resolved by any means yet, but in terms of getting the enterprise scale to address and support CalAIM and the interoperability, that those questions really need to be thought through and really need to be understood in order to do something at scale that could really benefit the counties and the municipalities all the way down to the actual providers. So there's a lot of work ahead, and I'm hoping that goes into a national dialogue around who else is doing that and how do you get the kind of support for that. And last thing I'll say is we'll be addressing some of the technical details around accomplishing that during the final webinar whenever we get that scheduled. So that will be coming up. So there'll be a lot more conversation around this stuff as we go forward. So let me just pause there for a second.
No, thank you, Daniel. Thanks for your leadership on this issue too, and your partnership in this work, and your point too around kind of the tissue and consent between programs. I see your question in the chat, Stephen, around the PMPs providing specific guidance, and we agree with Jim and around, I think the PMPs largely point to applicable law. I think, largely for the reason that there are a lot of laws out there, we're we're hoping to bring in a lot of health and social services organizations into the DXF, and I think there's so many laws that could take probably hundreds of pages to summarize them all in a PMP, but I do think that's where the SHIG, the State Health Information Guidance, the CalAIM data sharing authorization guidance are particularly useful in diving into not just summarizing law, but showing folks, where do you need consent or not in order to share information? And I think to speak to your issue around, personal representatives and where they may be able to provide consent to share information too. And I also like to see that the Sequoia Project's got a work group on this topic as well. Felix, I see your comment in here too around statewide consent registry. Did you want to share anything more about that thought in there around, how do we think about shared technology?
Not really, Robbie. The comment kind of stands for itself.
Awesome, thanks, Felix. Yeah, I think that we heard different
Let me
from folks, and Daniel, yeah, maybe you can speak to that in terms of where consent management sharing solutions kind of live or sit.
Right. Yeah. And I think that's the point I was trying to make, that there's been a lot of work that's gone on both in California and more broadly across the country. Obviously, a couple of places have benefited from the ONC LEAP grants. Those are, I think, are on their third iteration now. So from the work originally done in San Diego, now across Missouri, and now in Texas and a couple other places, there's some good technical foundational work that we've been looking at closely across the different standards groups, along with granular consent and identity management, that I think will be really important to, again, not recreate the wheel every time in every county on those things, but that there are things to build from on that. The caution, of course, is that because clinical medical care is so dominant and so much of the authority is placed in the plans, that there's a tendency to stay focused on healthcare data exchange and HIPAA related things, and social services and SDOH gets always put off to the future. In many ways, the exchange of healthcare data is covered. It's not that complicated. It's exchanging with behavioral health and housing and child welfare and those things that are more complicated. And again, I would encourage us, as we think about trying to address these things, is to start a little more ambitiously with some of the social services programs. And I know some counties are really doing that and working to try to do that effectively, but otherwise it just gets pushed down the roadmap so far down that I don't know how we would actually accomplish the SDOH kind of goals without putting it up front in the technical requirements, which is a lot more complicated, and some would say, than even just the healthcare, dealing with the healthcare pieces themselves. So there's a lot to be learned outside, and I think that there's now interest and momentum within the within Office of National Coordinator, within data modernization, within even CMS, granting some of the funding for this work, that we need to enable and to engage on the national level, where some of these solutions might actually bring value to us and spread across the country, right, as well.
Awesome. And I see we've got two hands raised, and then we need to move on to the next item. But Jim, I'll hand it to you.
Yeah, I would just add very quickly to Daniel's excellent comments, just for sake of discussion. Granular consent architecturally also implies synonymously that it is situational and dynamic. And situational and dynamic consent is just not something we've always thought about, i.e., I'll share this with you today, but I won't share it with you tomorrow. Or I'll share it with 3 people, but I won't share it with a 4th. That is really a new paradigm for thinking about these concepts of consent as we move forward and how we architect those. Well,
I love that, and I think that's a good segue into Brian with your hand up, our technical guru. You wanted to share?
Well, yes, actually, my response is non-technical.
Oh.
We have the technology, we have standards, we have open source solutions that we can start working with. What we are missing on the social care side of things is the equivalent regulations as we have right now for HIPAA, high tech, et cetera. We don't know what can be exchanged under what circumstances, what is considered to be sensitive or protected social care information versus what is protected and sensitive healthcare information. So I would suggest that that is one of the next things that we need to get lined up, is putting in place the laws necessary to protect social care information as well as healthcare information.
We're getting lots of props in the chat. Jim just gave you a +100. So I think I'll say too, you know, we'd love to continue the conversation on this. We definitely will be following up with lots of the promising practices and programs. Keep us updated too, as you know, many of you are tackling this issue in real time. We'll also keep our eyes peeled too. I know there's some comments around policy developments, HT1, SAMHSA updates to 42 CFR Part 2. So lots more to come on the subject. In addition, just on our next slide, we had two webinars on the subject already. So one around Ask Me, one around the law. You know, please check those out if you weren't able to make them. Really good conversations amongst those panelists. And then we'll have two more webinars, as Daniel mentioned, really focused around technology and then digital identities. So stay tuned for those invites as well. I think just moving us along, we wanted to touch on a couple DXF updates for folks. The big one is that we have QHIOs, which, I mean, I'm super excited about. I see you smiling, Bob. I think in doing the DXF education work, this is super exciting to, you know, share the list with folks who are interested in grants and potentially signing up with a QHIO. So 9 organizations have been designated as those qualified health information organizations. There will be a webinar on the 7th, as well as I'm quite sure this topic will come up on several upcoming DXF webinars and meetings coming up too that CDII is hosting. But we wanted to, you know, hear from folks. I know we've got some QHIOs on the line. Any thoughts, reactions, questions from anyone related to the QHIOs? All right. Well, we will follow up on this, I know, with our DXF education grant work. We are looking to host some sort of forum related to the QHIOs. So more to come on that. We'll keep folks updated and put that in the newsletter. I see some congrats in the chat. How can we find out what geographic areas the QHIOs are serving? Good question, Michelle. I think technically under the application, QHIOs should be able to serve any participants, but I think there may be more to come on that in terms of, you know, areas of focus in particular where they may have deeper connectivity today. And I think that's one of the items we'd love to follow up on too, in a forum, you know, to highlight, you know, where QHIOs are looking to serve participants. I see Laura's comment around San Diego Health Connect serving San Diego and Imperial. And I think, as you can tell from some of the names here too, Michelle, some, you know, really have come out of the regional health information organization model as well. So that's something we'll make sure to highlight in further materials and in events as well. Yes, comparing QHIOs, great idea, Michelle. We'll follow up with you on that. I think we relatedly wanted to highlight for folks that round 3 has opened up for the signatory grants. So that's for QHIO grants as well as technical assistance grants. If you've signed the data sharing agreement, that's your first step to being eligible to get these grants. There's a lot of money remaining, over 38 million, unless my math is failing me today. So there's a lot more money. And I think under, I want to say under the budget, a lot of this money needs to get spent soon. So definitely encouraging folks to apply. I think CDII has asked folks to get their applications in before December 15th. So definitely encourage folks to apply. We'll put some links in the chat. We also have some educational resources on our info hub for folks that are interested in learning more. I think one of the cool things here too is that there are umbrella grants available. I know several organizations have done that where they're pulling together to apply for, say, a TA grant together. And I know that there's some interest in that. So let us know if folks are interested in that. We can help you find the right help from the state in navigating that process. But I think super exciting with the list of the queues now in terms of kind of moving forward on those grants as well. And thanks for putting in the chat in case you're interested in seeing who got them in round 1 and 2. Olivia just put that link in the chat. And we've got this grant flyer in case you're interested in learning more, want to distribute this with your networks. We've created this as part of our education grant materials. We're always curious too, you know, what are the questions you have, barriers you're encountering, feedback, you know, one, we're asking that of our grant partners as part of that project to feed that onto CDI, but also, you know, how can we help get the message out there? What would be effective to reach your constituents? Let us know. We'd love to get the word out there about this grant money. Just additionally, what's next with the PMPs? I know this is top of mind for lots of folks as January 31st of next year fast approaches for go live, if you will, of the data sharing agreement. So a couple, as you can see here, are under development post public comment. One is currently out for comment right now, data elements to be exchanged. We'll touch on that in just a moment. But we're definitely eagerly awaiting those 3 that are under development. Hopefully, I think there's a PMP meeting coming up next week where fingers crossed we hear about those finalizations. We'll keep you all updated on that as well. So just related to the data elements to be exchanged PMP, what this PMP does is it sets forth those minimum data elements that participants must make available or exchange with other participants. A lot of that language comes from the enacting legislation itself, AB 133, in particular with regards to health plans as well as providers and hospitals. So some of the modifications that CDII has proposed are both administrative changes and substantive revisions. And public comments are due on the 20th of November. We'd love to submit comments. So we'd love input here today. We'll also review this again at our next meeting and welcome emails as well. Just on the next slide, in terms of what some of those changes look like, you know, one, clarify that participants are not required to exchange abortion or abortion-related services. This is really in alignment with AB 352, which I think in our last meeting we mentioned was passed, signed by the governor this year, and specifically states this. Additionally, another proposed change is to establish a precedence for data elements, terminology, and data format standards, and really clarify that the requirements for the participants in addressing gaps and standards to represent all of the data elements that must be exchanged if they're maintained by participants. And then lastly, we're replacing the term regulation with the clause law or the policies and procedures. Additionally, I think just to note, I know this was a topic of conversation at recent CDII meetings. There is not inclusion of an allowance for the continued use of legacy formats, terminologies, and data standards that organizations may have in use today. That was one of the points of discussion brought up previously. Should that be allowed? And additionally, don't allow for the exchange of claims using alternative standards as well, which was also considered. So I'll pause there. Any additional thoughts or comments or questions from anyone related to this PMP? Well, I think as a next step, what we'll do, we can draft something up for folks. I think it would be relatively short, and we'll share that with this group for consideration at our next meeting in 2 weeks. So I think with that, Olivia, I'm going to hand it to you to walk us through some of the updates related to California Health Interview Survey.
Perfect. Hi, everyone. Drop in a link to that in the chat. And yeah, we want to just spend some time highlighting that a bunch of new data is now available. And it's the most comprehensive source of information on people living in California. It was conducted from February to November of 2022. So we have, I believe on October 4th is when the 2022 data, CHIS data was released. And it really asks about a huge range of topics, health status, health conditions, demographic information, health insurance coverage, access to services. So a lot of great insights that we wanted to, just bring to attention for people that missed the launch webinar that happened earlier. And there is a lot of data that's available. So if you haven't had a chance to go, explore CHIS or look at data available in CHIS, would highly recommend. There are currently 391 variables or different topics that are that are available, and there are ways that you can cross tabulate data to look at it for a more granular view. And gosh, I believe now they have approximately 10 million different CHIS estimates that you can explore. So highly, again, recommend checking it out. And moving into some of the highlights, we learned that in 2022, California actually had its highest health insurance coverage rate, which is very exciting. And it is a statistically significant increase from 2021. And we're looking forward to what the results will be for 2023 and 2024 moving forward as we expand Medicaid coverage as well. Although insurance coverage was very high, there were more issues with people actually accessing care. People were able, there was a decrease in people visiting their doctors during the pandemic in 2021, for example, and they're seeing that these rates are starting to rebound, which is good. Same with dental care. It's now actually increased pre-pandemic rates, which is great. But there have been statistically significant increases in people not being able to get an appointment within 2 days when trying, or not, having issues with doctors actually accepting patients in recent years. And similar trends too with people accessing mental health care. There are rising numbers in people seeking mental health care for mental or emotional or SUD related issues after the pandemic, but they are also having more difficulties actually accessing this care. So for example, in 2022, 33.3% of people that sought an appointment had difficulties actually getting an appointment. And that was the reason for why they did not receive the care that they needed. Oops, sorry, I think I skipped a slide. There are also rising rates of food insecurity post-pandemic. 44% of adults were not able to afford the food that they needed. And we've also seen an increase in people receiving food stamps. Looking into telehealth, there was a huge bump in telehealth, which, nothing new, nothing surprising there. So 49% of adults, 49% of adults interacted with telehealth in 2021. And this rate seems to have stabilized, give or take, at 46.7% in 2022. So that's great for telehealth moving forward. And we wanted to also highlight that there are discrepancies between people using telehealth by their race and ethnicity, with the Latinx population actually having the lowest rate, but the American Indian and Native Alaskan population having the highest rates. Oh, sorry, before I wrap up there, I guess, does anyone have any questions? We did want to highlight too that, these survey results are really insightful. And, as we move forward with the DXF and unlocking a lot more data, it's going to be really interesting to see how much more we can learn, but from aggregating claims and other types of data sets in the state. And thank you for Robbie for adding in that link about our telehealth policy meeting that's coming up on November 8th in Sacramento. If people are available, they have a great speaker lineup that you can check out. And Daniel, I see you have a question. Is this data for total population? Does it break it out by Medi-Cal and private providers? I believe that they surveyed about 21,000 adults in total, but they were able to generalize this for California's total population. You are able to cross-tabulate data. So I have a feeling you would be able to break down, telehealth usage or, access to care measures by type of health coverage. And yes, yeah, you can slice the data in many different ways. So it's very cool to look at. And Daniel, if you want to come off mute, I see you also have your raised hand or your hand raised.
Oh, yeah, I was just trying to get your attention there. No, that's really good to know, because a lot of the conversation we've been having around the consent is between the third of the population that's Medi-Cal covered, and then the rest of the population saying, hey, we need those same services. So when we start to look at data and trends and access, my assumption is that it would look very different for a Medi-Cal population than the general population. And how do we look at that? I would imagine those breakouts would be obvious already, or already broken out to be able to look at it, but the average is probably not accurate in terms of an observation of it. I did have one other question. I don't know, a number of years ago, I got exposed to the AHRQ at the federal level. I was blown away by the survey that they did, and I wondered if you were familiar with it and whether or not there was any sort of cross correlation with that, because they survey on a regular, ongoing basis tens of thousands of people across all sorts of lifestyle and all sorts of health issues, and different federal agencies are able to put in different questions into it. I had never seen such a large, persistent survey over such a long period of time. And I know CHIS is an incredible resource, but I didn't know if it was cross-reference with any of the other kinds of things that are out there.
I'm sure that they look at similar measures, but I haven't actually looked at the AHRQ survey results, so I'm not entirely sure. Yeah, the crossovers between the two.
The researchers always complained that it was a well-kept secret, that more people didn't know about it because it was so broad and deep and longitudinal. So anyway.
But I think it's great too to have that longitudinal data so we can track trends over time. So I'll definitely have to take a look at that. Thank you. And are there any other questions that I missed before we move on to our news, events, and announcements?
I actually had one question. I not living in California, I don't know how widely that information is shared to the population. Is it generally picked up by media, and are there exposés? Is it available to people and communities in terms of who might want it, or is it mainly remains in the academic and government communities?
I'll say I don't know how much the public is fully aware of this data being available. I know that researchers use it a lot, and UCLA creates a lot of great issue briefs using this data. So there is some news coverage that they definitely get on this information. Sorry, I'm trying to think of what my other thought was on this. Oh, I wanted to highlight that ITEP actually. They do a great job of actually creating profiles. So they recently, I believe, released a California-wide profile using some CHIS data, but they actually create regional dashboards too, and some county level as well, using CHIS data. So would definitely, I'll try to find that link and drop it in the chat real quick. But there are people that try to bring this data down to the community level. And I'll add to, and I guess quick preview for what's to come, but I know with our PATH collaboratives that Blue Path Health is involved with, we are looking at creating more community level dashboards. So I have a feeling we'll be pulling from this recently released CHIS data.
If I could add one more comment to that, at the community level, I think one of the things that big system change processes and programs always look for are reflective and respectful use cases and case studies. And having the information, years ago when we were putting use cases together in personas in California, we actually used some available data. We didn't use the CHIS data, but that might be a really interesting connection relative to the CHCF paper in terms of creating use cases by community that are actually reflective of those specific community members, and you have the data for it. So it's kind of like leveraging that in a way that could be really useful and accurately reflected the differences in each of those communities, which is what the ultimate goal of it. Because sometimes there's so much data that we don't end up using it for anything, except for more research. And I'm always interested in figuring out how to apply it in some way that's really useful. So
Yeah, no, I think that's a great point. I think that's something that the Path Collaboratives can really try to highlight with this data. So, to help people kind of understand specifically what's going on in their communities, what the trends are, and what types of interventions are really needed.
And if I could ask you one final question, then I'll shut up, I promise, are there, I don't know if it just includes attitude and usage data as well, or is it mostly descriptive statistics?
I would have to get back to you on that.
Okay.
Yeah, I'd
Yeah,
have
and
to
the
get
reason-
back to you on that. Mhm.
Okay. I don't know if anyone else has that understanding of it, because that's really powerful consumer data that tells people about, who's using the services, how well those services are received, and what people think of them in a large scale.
Yeah,
that
there's
can be
definitely
very-
information about they have a lot of like access measures, but not entirely sure if they dive deeply into people's perceptions on the services that they receive.
Mhm.
Well, moving forward, we have about 10 minutes left. We wanted just to highlight some news events, and I don't believe we have any announcements this week. So again, if you haven't signed up already, definitely please sign up for our newsletter. You can stay up to date on what the coalition's doing and all the latest, DXF news and other data exchange related news. We highlighted this week that there is a new $10 million initiative actually for modernizing WIC programs across the country between Johns Hopkins, the National WIC Association, and Benefits Data Trust. And they're working on using data-driven strategies with data matching and updating outreach systems to help people actually identify eligible members and help get them enrolled in services, which, as we've been highlighting with all of our WIC work, there's definitely a need there. Only about 50% of people in, I believe it was 2020 or 2021, 50% of people who were actually eligible for WIC were enrolled in it. So there's a lot more work to do there. There's also, ONC actually also highlighted some data from the Health Information National Trends Survey, HINTS. And it revealed that about 6 in 10 Americans were comfortable with their health providers sharing information about their social needs with other providers for treatment purposes. It depended on the type of social need information. So people felt more comfortable, sharing if they had transportation issues. And people were a little less comfortable when it came to like sharing information about their housing status. But I think it's great to see here that there is, the public is, either very or somewhat comfortable with sharing this information for treatment purposes. And I think as we continue to develop programs that are actually addressing these social needs, I have a feeling that these percentages will increase over time. And we did want to highlight as well that there is a Stewards of Change. So Daniel, thank you for being online today. You guys released recently your consent learning lab report. So if there's anything you want to share on that, we'll have to drop the link in the chat for that.
Yeah, I think that I put a link in there earlier, but we can add another one. It actually is just it's the meeting recap from HIMSS when we were talking about consent with a bunch of people from across the country, and several folks from California were there as well and participated. So it's an interesting sort of comparison with some of the key themes and obstacles and opportunities that are very parallel to the report that we just put out also with CHCF, California specific. So there's a lot of corollaries between those two, and there's information from around different places as well. That's a good resource that just became available during Global Health Equity Week, which is happening this week with HIMSS.
Perfect. And then moving on, because we only have a couple minutes left, we want to highlight some upcoming events. APG has their annual conference coming up in Washington, D.C. We also mentioned the California Telehealth Policy Coalition and eConsult Work Group. They have their annual meeting, I believe, next week. No, actually, the week after, in Sacramento in person. The Community Clinic Association of Los Angeles County, representatives from Blue Path Health will be there speaking on a panel about the data exchange framework, reflecting back on 2023 and, what's to come in 2024. CAF also has their annual conference coming up in Palm Desert. And we wanted to highlight a new conference that or a new policy forum that people may not have heard about yet. RISE and Aligning for Health is having their second annual social determinants of health policy forum in Washington, D.C. And Timmy's actually going to be there speaking on a panel, which we're very excited about. And also ITEP has released information about their annual conference in Sacramento for next February. So definitely get that on your calendars. And there are also, we normally don't highlight webinars, but there's a lot of good ones coming out that we wanted to bring to people's attention. Next week, we have the Calian Data Sharing Authorization Guidance. They're releasing the updated guidance. We've seen the draft one that I think was released back in June. So it's exciting that we'll be getting the finalized guidance coming out soon. We also have the DXF Policy and Procedure subcommittee meeting next week on October 31st. And I believe that they're going to go into more detail on the participant directory PMP that's coming out soon. So if you're interested in that, I think that will be a heavy topic for discussion there. The DXF Multi-Association Education Initiative has office hours coming up as well. So if you have any burning questions that you want answered, would definitely recommend coming there and getting some answers. We have ONC is doing an interesting tech forum on aligning US CDI, FHIR, US Core, CCDA, and other health IT standards. So if you're interested in, getting more up to date on what all these different data sharing standards are, I think that'll be a great crash course for people maybe newer to that field. And we also have on November 7th, the DXF webinar number 13, where we expect the QHIOs to be a big topic of conversation there. And finally, looking later into November, we also have the DXF Implementation Advisory Committee meeting. So get, the two highlighted in yellow, definitely get those on your calendars coming up. And I will pass it back to Robbie with 3 minutes left to go.
No, thank you, Olivia. And thanks everyone for joining today, participating. We'll be following up on a couple items coming out of today. We'll keep folks posted on what comes out of the PMP meeting next week. And we'll see you all in 2 weeks on the 9th. But hope to see you as well in the meantime at some of these events, virtually and in person. So thanks everyone and take care. Have a good rest of your Thursday.
Thank you, Robbie. Thanks all.
Thank you. Take care.
Thank you all.